So next we'll see about thalassemia. So thalassemia is again a hemolytic disease. Here the normal hemoglobin, I told it is going to be composed of 2 chains of alpha and 2 chains of beta. So alpha to beta 2. So the gene for alpha chain is going to be present on chromosome 16 and it is represented by 4 genes. While the gene for beta chain is going to be represented on chromosome 11 and here again it is going to be 4 genes. So whenever the genes for alpha gene is going to be deleted, okay, just remember it is going to be deleted, it is going to result in alpha thalassemia. So alpha chain is problem resulting in alpha thalassemia. While the beta chains, if they are getting mutated, mainly nonsense mutation, it is going to result in beta thalassemia, right? So each of this word is going to be important. Alpha chain, alpha genes in chromosome 16, beta genes in chromosome 11. Deletion is going to cause alpha thalassemia, while nonsense mutation is going to cause beta thalassemia. Okay, so this beta thalassemia is the one which is going to be more common than the alpha thalassemia. So under beta thalassemia, let us see what is the pathogenesis here. So at the beta chain, the beta gene, if you see, the mutations can be a nonsense mutation. Missense mutations is going to be there in sickle cell anemia, nonsense mutations in thalassemia. So mutations at the beta gene, if it is at the promoter region, it is going to result in a beta plus phenotype. While if it is present at the chain termination region, it is going to result in beta naught phenotype. If the mutation is present at the splicing region, it is going to result in a beta plus phenotype again. So beta plus again for promoter and the splicing region, chain terminator region, it is going to result in beta naught phenotype. And this splicing mutations is going to be the most common mutation which we see in beta thalassemia. Okay. So if you see, the normal chain is going to be represented as beta beta without any plus or 0, right? So beta beta is normal hemoglobin beta chain. If it is beta beta plus, so it is going to result in mild anemia, that is it is going to be more than 10 gram percentage. So it is going to result in thalassemia minor. Beta plus phenotype is going to result in moderate anemia, resulting in 6 to 9% of hemoglobin, resulting in thalassemia intermedia. If you have a beta naught with either a beta naught or a beta naught with a beta plus, it is going to result in a very severe anemia, which is less than 6 gram percentage. So these patients are going to be transfusion dependent and it is called as thalassemia major. Okay. So let's see about thalassemia major first. Thalassemia major, as I mentioned, here they are going to have severe hemoglobin. So from birth, they are going to be dependent on transfusions. So it is called as transfusion dependent anemia or Cooley's anemia. So here, as the name suggests, there is going to be beta naught and along with beta plus combinations, right? So there is going to be very much reduced levels of beta chains. So whenever beta chains are being reduced, the unpaired alpha chains in the adult hemoglobin, right? So HbA is alpha to beta 2. So when beta is defective, so there is this excess alpha which is present, right? So this unpaired alpha chains tends to precipitate. So these precipitated alpha chains will now cause the damage to the RBCs. So when RBCs are being damaged, it is going to be this precipitated alpha chain, right? So it is when it is going to pass through the spleen, it is going to result in extravascular hemolysis. So whenever there is hemolysis, there is going to be anemia. So it is going to result in anemia. So with anemia, the bone marrow is going to try to compensate for the hemolytic loss. So it is going to try to increase the erythropoiesis. So bone marrow will start expanding. So even then it is not going to, it is not able to overcome the defect. So there is going to be expansion of bone marrow everywhere possible, and also in extramedullary hematopoiesis is going to take place. So not just in bone marrow, it is also taking place in the other sites like liver, lymph node, spleen. Okay. So extramedullary hematopoiesis will take place. So because of this, it gives the characteristic appearance in thalassemia babies called as thalassemia faces. So what is thalassemia faces? If you see, this is the characteristic image here, this baby. They are going to have frontal bossing. So frontal bossing is going to be there along with malocclusion of the tooth. So the tooth is going to appear abnormal. Then crew-cut appearance of the skull or hair on end appearance. So this is the characteristic image. So frontal bossing is going to be there, malocclusion of the teeth is going to be there, and then there is going to be this kind of an appearance She's looking as if there is hair sticking onto the skull, right? So it's called as a crooked skull or the hair on end appearance. So all of these features are actually a result of the extramedullary hematopoiesis and also the bone marrow expansion. Okay, so all of this actually resulted because of the anemia. So there is going to be severe anemia. So how much ever the bone marrow is trying to compensate for it, it is not able to compensate, and the patient goes in for a transfusion dependency. So when there is this extravascular hemolysis, so obviously with RBC breaking down, iron is going to be released. So lots of extravascular hemolysis is going to happen. So lots of iron is being released. So this iron is going to cause iron overload. So in thalassemia patients, there is going to be a state of iron overload. Not only that, these anemia patients, they are having very severe anemia, right? So they are transfusion dependent. So they'll have to transfuse the blood continuously throughout their life. So because they are transfusing blood continuously, that also leads to a state of iron overload. So in thalassemia, you're going to have a state of iron overload. And because of this iron overload, again, there is going to be problem. So what happens? Like a hemochromatosis patient only. So here the iron which is present, it is going to derange the HPA axis, hypothalamus pituitary adrenal axis is going to be deranged. So that will result in the stunted growth. So stunted growth will be there, hypogonadism can be there. Apart from that, the islets of pancreas can be affected. So there can be diabetes mellitus, and then cardiomyopathies, restrictive or a dilated kind of a cardiomyopathy can be result in cardiac failure or a liver dysfunction. So the excess iron can go and deposit in the liver, causing liver cirrhosis. So it is more or less the same features of the hemochromatosis, right? So here there are multiple complications in these patients. Firstly, because of the extramedullary hematopoiesis and the lots of this bone marrow expansion, there is going to be characteristic phases associated. Then apart from that, there is going to be lots of extravascular hemolysis happening, resulting in anemia and then causing iron overload also. And this iron overload is further going to cause this defects, right? So this is all for thalassemia major. Let's move on to thalassemia minor. So in thalassemia minor, what you have is, it is also called as the thalassemia trait. So here the combination can be a normal beta chain along with a beta plus or a beta naught. And here these patients are usually asymptomatic. They don't come in with any complaints. So usually they are detected when they are randomly testing for any peripheral smear or a CBC. Usually they present for in pregnant females. So in pregnant females only, during their screening time, many of the thalassemia traits are being detected. So this is all these thalassemias are going to be autosomal recessive, right? So you'll have to be careful. So if you check a pregnant female during screening and you test for her and she comes out to be thal trait, so you'll have to check for the husband also. If the husband is also having some thal trait, the chance of developing producing a kid with a thalassemia is there. So that you'll have to explain the risk, and the child they'll have to undergo a prenatal screening. Okay. So the characteristic findings in a thal trait is going to be, it is a close differential for IDA, I told, right? So the picture is going to be of microcytic hypochromic anemia. So microcytic hypochromic anemia is going to be there. Then there is going to be mild anisopoikilocytosis and the presence of target cells. So lots of target cells will be present in thalassemia. So target cells, teardrop cells. So this kind of picture will be present. So in this picture, if you see all these cells, these are all target cells, meaning they are having a peripheral ring, and then in the center there is a dot of pink dot, right? So these are all looking like the target. So these are target cells which are seen classically in the thalassemia patients. You can see it in any hemolytic anemia, but more of target cells is commonly seen in the in this thalassemia. So these are all the teardrop cells which we see here. Apart from that, you are seeing this kind of microcytic hypochromic kind of RBCs as well, right? So this is the classical features of thalassemia minor. So how do you differentiate it from IDA? I told you have to use the Menzer index. So Menzer index is MCV upon RBCs. So it is going to be less than 13 in thalassemia and more than 13 in IDA. So here again you can have a screening test for diagnosing this thal minor trait. So you'll have to use a test called as Nestroff test. So Nestroff test stands for naked eye, single tube, RBC, osmotic fragility. So it is a form of osmotic fragility only, but here you are using just a single tube, unlike a osmotic fragility in hereditary spherocytosis. So here if you see, you are going to take 5 ml of a hypotonic saline again. Along with that, you are going to mix 0.2 ml of the patient's blood. And then what happens, the RBCs will be lysed because of the hypotonic solution. So when RBCs are lysed, you will have to keep a paper with lines drawn on it behind the tube. So when RBCs are lysed, you can clearly see the lines behind. But in Taltrate, if you see, the RBCs are going to be quite resistant to the hemolysis here. So, they are going to be much more resistant than the normal RBCs. Okay. So, they don't lyse. So, when they don't lyse, what will happen? They are going to be present there only. They are not going to settle down. So, the lines behind cannot be seen. So, this is the basis of Nesterov test. In osmotic fragility test in HS, it is going to be elevated. While in Nesterov test, in thalassemia, here the Taltrate cells are going to be resistant to lysis. Okay, so the investigation of choice here would be the HPLC, like any hemoglobinopathy, right? So in HPLC, the classically, if you see, this is the diagnostic criteria as such. If you see HbA2 levels, which is more than 3.5%, it is diagnostic for Thal minor trait. Okay, so HbA2 normally it is levels is going to be less than 3%. So if you see this kind of elevation, so this is the HbF present here. So this is the HbA which is seen, and then you are going to have this HbA2, and their levels also they had given it is 4.9% here. So you'll have to look at the HPLC graph. Nowadays they are asking these kind of questions, so pay attention. They could ask either of it. So sickle cell anemia, thalassemia, all of this can be asked. So 4.9%. So definitely it is more than 3.5%. So it is a case of Thal minor. Okay, now let's see about alpha thalassemia. Okay, so in alpha thalassemia, I told 4 genes are going to be encoding for the alpha chain in chromosome 16. So it is here the pathogenesis involving the deletion. It is not mutation like it's not nonsense mutation as in a beta thal. It is just going to be deletion here. So if one gene is there is going to be 4 alleles, like 4 genes, right? So if one gene is going to be deleted, it is just going to be asymptomatic, no effect. If 2 genes are going to be deleted, it is going to result in alpha thalassemia trait. If 3 genes are going to be deleted, it is going to form HBH disease. In HBH disease, it is actually the pathogenesis is because of formation of beta-4 tetramers. So here the alpha chains are deleted, but unpaired beta chains are going to be there, right? So the unpaired beta chains are going to form tetramers, and that is going to cause problem in this patients. If 4 genes are deleted, it is going to result in HB Bart's disease. So HB Bart's is not compatible with life, and it is going to cause intrauterine death itself. So you don't get to see patients with HB Bart's. So in HBH disease, you have a classical finding, again an image-based question. So if you see this HBH disease on supravital staining, like for reticulocytes, you can see the RBCs are entirely filled up with these kind of inclusions. So multiple inclusions are going to be present. So all of these inclusions are basically beta-4 tetramers only. So it is causing HBH inclusions, giving an appearance of golf ball. So golf ball kind of an appearance is seen in HBH disease, right? So till now we had seen supravital stains for various things, right? Firstly for reticulocytes, then for Heinz disease we saw, then for this HBH golf ball appearance, you can use the supravital stain. Okay, so now we had finished about all the thalassemias.